Hi, everyone. I'm Marion Kregeloh, and I'm the creator of Alex for Hope, a website. And I created that since my son's tragic passing from fentanyl poisoning in April of 2020, after years of a devastating struggle with addiction to Xanax. And I have begun to raise awareness about mental health, addiction, and fentanyl awareness and trauma-informed system building. And today I'm talking with Dr. Anna Lembke about Xanax and why it has become popular, sadly, among youth, and why we call it a quiet epidemic. So before we start with the talking, I would like to introduce Anna shortly, even though she has a very extensive clinical background. Anna Lembke is a professor of psychiatry at the Stanford University School of Medicine and chief of the Stanford Addiction Medicine Dual Diagnosis Clinic. She's a recipient of numerous awards for outstanding research in mental illness, excellence in teaching, and for clinical innovation in treatment. Anna asked me to shorten the bio. It would go on, but I want to mention that you have written a book. One came out in 2016, Drug Dealer MD, and the other one last year, Dopamine Nation. Highly recommend those books. And if you want to know more about Anna and what she does, you can visit her website at annalembke.com. So Anna, thank you so much for taking your precious time to talk with me today. This is really for parents, families, teens, and anyone who takes benzos, wants to know about it, and why is it so important to know about. So I'm diving right in. Tell us, what is Xanax? What kind of a drug is it? Maybe a brief history, and how does it work? And let's begin with talking about the prescription drug.
So prescription Xanax is in the broader class of benzodiazepines. These are drugs that bind to specific benzodiazepine receptors on the larger GABA receptor. GABA is our inhibitory or calming neurotransmitter, and neurotransmitters are the molecules that bridge that gap between neurons called the synapse. The other drug that works on the benzodiazepine receptor is alcohol, and sometimes we talk about benzodiazepines as alcohol in pill form. Xanax is one of the most potent and also potentially most addictive benzodiazepines. Other benzodiazepines include things like Valium, Klonopin, Ativan, things that your listeners will have heard of as well. But what sets Xanax apart is that it has a very fast onset of action. And so it works very, very quickly. And we know that things that work very quickly tend to be more addictive, because when people are reaching for a chemical to change the way they feel, if it changes the way they feel, almost instantaneously, that is very reinforcing for the addiction cycle. That's Xanax. It's a benzodiazepine. Again, it works on the GABA receptor. I don't know exactly, I can't remember exactly when it was FDA approved, but it's been around for quite a while. And over the past 20 years, we've seen a rising prescribing of benzodiazepines for all kinds of conditions, from vertigo to seizures to depression to anxiety, in ever younger age cohorts and also ever older age cohorts. And the very young and the very old are the people who are the most vulnerable to the adverse effects of benzodiazepines.
And then you mentioned the indications. Can you maybe summarize what are, in your experience, the key and also the appropriate indications for taking Xanax? And are there such indications that we would refer to as off-labels that are also being used? Maybe you can clarify that a little bit.
Well, the main things that Xanax and other benzodiazepines are used for is anxiety, insomnia, and seizures. Those are really the main things. And then sometimes, and not sometimes, but they're often used in anticipation of a medical procedure, like going in an MRI or, even during certain surgical procedures. And they play a very important role and are evidence-based for those indications for short-term use. And this is probably the most important thing that I can communicate to your listeners, is that benzodiazepines, including Xanax, have scientific evidence to support their use as long as they're used short-term. So the studies of benzodiazepines on average last 1 to 2 weeks. That's really important because very often they're being prescribed for much longer than that, for many weeks to months to years to even decades. And that is very problematic because we don't have evidence to support their use long-term. There are no studies showing that they actually help these conditions when taken daily for long periods of time. And there's mounting evidence that they can cause significant harm. For example, in the Journal of the American Medical Association, just last month, there was an article published showing that benzodiazepines can increase all-cause mortality. That means increase the risk of death from all causes, even when taken alone. So we have known for some time now that in combination with opioids, the risk of death goes up twofold compared to, for example, taking an antidepressant, and fourfold compared to somebody who's not taking any kind of psychotropic. But what was really important in this study is showing that the risk of death of benzodiazepines, even without an opioid, are significant.
And you're talking about prescription benzos at this point. There is that risk of fatality.
Yeah, so this is really important, that benzodiazepines, even when taken as prescribed by a doctor, can cause harm. And beyond that, very often people who get a prescription from the doctor misuse that prescription. And misuse means taking it in any way other than prescribed. Some people are doing that, intentionally to get high, but most people are doing it as a way to kind of manage their mounting symptoms as they develop tolerance to the Xanax. Because what happens with benzodiazepines is that over time, our brain adapts to that drug so that it's no longer working. Now we need more of the drug in more potent forms to get the same effect. And when we're not using, we're experiencing rebound insomnia or anxiety or whatever it is that we're taking the Xanax for in the first place. So importantly, again, in addition to increasing risk of all-cause mortality, what Xanax can actually do over time is make anxiety worse, make insomnia worse, make vertigo worse, or whatever the indication is. And this is what people really need to understand, that this is a short-term drug. Taken long-term, it causes many other problems.
Wow, that's a lot of important information. What is the proper use? Let's say a doctor is prescribing Xanax. What would be a starting point? And for how long? I want to come back to not taking it too long. You said something about 1 or 2 weeks. What is a time period that's considered safe or appropriate?
Well, I think, first of all, I would want to emphasize that anytime a doctor is prescribing Xanax to any patient, they should be giving that patient full informed consent and information about the risk, benefits, and alternatives. And in general, that is not happening. And the reason it's not happening is because in medical school and NP school and what have you, in medical education more broadly, providers aren't really learning the true risks and benefits of benzodiazepines, so they can't pass those risks, the information about those risks onto their patients. But in some ideal world, what would happen is that the doctor would let every patient know to whom they're prescribing benzodiazepines that these medications are potentially addictive and potentially lethal, and that even patients taking them as prescribed for a bona fide medical condition can develop addiction and die from these drugs. So it's really important that patients recognize that these are serious and dangerous drugs and should not be taken lightly. Furthermore, the doctor should let the patient know that if these drugs are going to be taken daily, they shouldn't be taken for more than 2 weeks daily. Because there's no evidence base to support their use beyond about 2 weeks, maybe some studies showing benefit at most to 4 weeks, but none beyond that. And if they're not going to take them daily, they can be used intermittently on rare occasion, for example, for a specific phobia like flying. That is appropriate use as well, is to, have a limited supply of something like Xanax that one would use very, very infrequently for peak anxiety. But even then, there are better ways to target specific phobias and other forms of anxiety, panic attacks. Behavioral interventions and psychological interventions are more effective over the long haul than taking a pill for any of those anxiety forming conditions. Same thing with sleep. A patient who's going to use a benzodiazepine rarely and intermittently, no more than about 1 to 2 times per month, that's probably appropriate use. But anything, a lot more than that, and then patients risk becoming physiologically dependent, developing tolerance so that it stops working at that dose, getting rebound insomnia, and ultimately getting dependent and potentially addicted.
Wow, this is amazing, because this is clearly not happening yet. And I can talk in my own experience as a physical therapist in chronic pain. I have so many patients when I'm going through their medication lists who take Xanax for a long time. It just becomes their best friend. I sleep better, and that works for my anxieties, but they often take other things too, sometimes on top of that. And when you have someone like, for example, a young person who has a prescription for Xanax, what would be a dose you think, in your experience, would be appropriate to start them? And again, would it be the same 2 to 4 week frame max?
I guess I would want to take a step back and emphasize that I almost never prescribe Xanax. It's just so high risk in terms of the acute and immediate reinforcing effects, putting that individual at risk for addiction, especially a young person. So I personally don't initiate Xanax prescriptions, and I would broadly recommend that other physicians and prescribers avoid Xanax as well. It's also developed a kind of a sort of a cult or symbolic kind of trendiness among young people, which I think also contributes to its addictive potential. It's, cool to take Xanax, and especially in certain drug worlds. And it has a lot of, there's a strong street market. So an opportunities to divert the Xanax prescribed by me and others, and to sell it for other drugs. So I generally don't recommend, Xanax, and I even resist prescribing other benzodiazepines, especially to young people, because young people have, an enormous amount of brain plasticity and a wonderful ability to learn other coping strategies. And I would emphasize that well before I would prescribe a benzodiazepine. I will tell you that in the beginning of my career, I prescribed a lot of benzodiazepines. So this has been a shift in my understanding over time as I've seen patients misuse, become dependent on, and get addicted to the benzos that I and other psychiatrists and other providers are prescribing or have prescribed without appreciating the dangers.
And I will come back a little bit, because you're answering so many of my questions. You're already going into all these important info, because I want to stress some of that so that listeners can hear it maybe again on a deeper level. So I want to talk about why is Xanax so popular in the world. So number one, why have the prescription Xanax become so popular? You mentioned it has been prescribed very casually. So there is some overprescription going on. And patients sense, well, if it's prescribed, it's safe, and liking the initial effect and believing it's good for me, I keep taking it. What are other reasons that it's so popular?
Well, the pharmacology, as I mentioned, is a big reason. It's got such a rapid onset of action that it's immediately reinforcing in ways that I think is distinctly different from other benzodiazepines. So that's another reason. And then, of course, in popular culture among young people, certain, music culture, other types of popular culture, Xanax has developed a certain cachet. It's kind of cool, it's rebellious. Also, just people, who are into using drugs recreationally, hear about it because of the high that's associated with it, either alone or in combination with other drugs. So then it's sought after because people talk about its reinforcing effects.
So it sounds like there's quite a deep and widespread, almost like an ignorance about the dangers of that drug on all sides.
Yeah, so a couple things there. So one of the things we've learned about prevention or our difficulties, preventing addictive substance use, especially among young people, is that sometimes, especially with young people, when you talk about the dangers of a particular drug, instead of making them not want to take it, it makes them want to take it. So it's not just a matter of, educating people about the dangers, because like I said, with young people who are prone to taking risks and looking for danger, that might be something that makes it potentially appealing, which makes it difficult to know how to educate people about the risks, especially young people.
Yes, and what you mentioned, the casual perception, I think there is some normalization about it. As you said, in the music, rap, pop culture, I've heard it so many times.
Yeah.
In the past, before my son passed and before I even knew he had an addiction to Xanax, I probably wouldn't have thought much about it because Xanax was never in my consciousness. And now I'm having a reaction when I hear it. And
Sure.
I think the normalization is a true problem because that's hard to get out of that deeply penetration. As you have written so much about that in your book, Dopamine Nation.
Yeah.
I think that, that requires such a rewiring of us all together.
Yeah. You're reminding me to say what's even more important than its popularization in music culture and popular culture is just the broad, the sweeping normalization in our culture about taking a pill to chase away any kind of negative feeling. So, 30, 50 years ago, it was very strange to do that. People were used to tolerating more distress. There was this idea, 100 years ago that pain was actually good for you. When general anesthesia was first invented in the mid 1800s, the leading surgeons of the day didn't want to use it because they believed that, pain to some extent was healthful or salutary, that it boosted their immune response, that it sped up tissue healing. In fact, what we're seeing now is that might actually be true. That, for example, patients who go through opioid sparing surgery might actually heal faster and have a more robust recovery than patients who get opioids during surgery. But the point is that there's been a sweeping transformation in modern American culture to this idea that, what if I'm in distress, I must be sick, and therefore there must be a pill that I need to take to get rid of this feeling. And I think that's really where we need a sea change in our culture. We've pathologized everyday life. We have to change the threshold around which we decide, okay, this is abnormal suffering and somebody needs to step in.
I so agree with you. And it's so wonderful to hear this from someone you're an expert in your field. And I wished most people who struggle have someone like you with your experience and your approach and your belief about benzos alone. I want to come back about briefly before we dive more into what the dangers are about Xanax. What are the different types out there? So number one, we have the prescription drug, the one that historically was coming from the pharmacological world. But we also have two other types. Would you talk about that and just kind of what is the distinction between all three?
Well, we have diverted Xanax. So this is Xanax that the individual obtains not directly from a doctor, but indirectly from somebody else who got it from a doctor. And that's an illegal form of Xanax. Illegal because even though it's pharma produced and pharma dispensed, it wasn't issued to that individual. They bought it from somebody else or got it for free from somebody else. And the most common way that people who misuse prescription drugs get them is actually through a friend or family member. About 50% of people who misuse prescription drugs get them from a friend or family member. About 30% get them directly from a doctor, which is a pretty large percentage in itself also. When you think about the fact that the vast majority of those doctors have no idea that the patient is misusing the prescription. The other form of Xanax is Xanax that's manufactured in an illicit laboratory. So it's not made by a legit pharma company. It's made by drug dealers who are working, cheaply with those chemicals to produce Xanax, and put it out there on the market. And then, of course, you have the problem of, quality control and not really knowing what's in them. And they have the ability to make those Xanax pills look exactly like the pills that are made by the pharmaceutical industry. So that's why they're called counterfeit Xanax pills. And often those counterfeit Xanax pills have been adulterated with other substances. For example, just inert substances that don't do anything, but that allow the drug dealer to sell it as if it were real Xanax, even though it doesn't have maybe any real Xanax in it. But the more dangerous problem is the problem of putting other more deadly and more potent drugs in what appears to be a Xanax pill. And namely, we're talking about fentanyl here. So lacing a counterfeit fentanyl, a counterfeit Xanax pill with fentanyl, and fentanyl is a highly potent opioid, 50 to 100 times more potent than heroin. And therefore, people who are taking it, either knowingly or not, are at very high risk to die from that opioid, especially in combination with the benzodiazepine, because that particular combination is more deadly than either benzos or opioids alone. The most common range for any drug is between about ages 15 to 25 and 30. So we see a huge spike, and that's been true for forever, right? Young people who are less risk averse, who are, in the prime of their socializing life. There's a real contagion effect with addiction and substance use. It can spread through communities like a virus from one person to another. So young people hear about other people using drugs and they want to experiment and try that out. So that's really, where we see the most prevalent use, and also the highest rates of addictive use and overdose death.
So when we want to prevent the dangerous use of Xanax, and now let's talk about those black market Xanax that are so popular among young people, what do parents or families need to know? And also maybe share what could be symptoms of anxiety when the child isn't diagnosed, but the child is anxious. What are classical symptoms that parents may want to look out for?
Well, symptoms of anxiety, can manifest in all kinds of ways. They can be completely internal and not show anything on the outside. People can, all the way to having a full-blown panic attack where people are sweating, they're looking around, in a panic state, feeling like the world is imminently coming to an end, and everything in between. OCD is a form of anxiety, so obsessive compulsive disorder, that's considered an anxiety disorder. PTSD, post-traumatic stress disorder, is considered an anxiety disorder. So these are all different manifestations of anxiety. I'm sorry.
And I believe that like being isolating and withdrawing can also be a sign that parents want to look out for. But now when their child is using Xanax, self-medicating without a prescription, parents don't know what could be some signs that parents can watch initially for that may make them suspicious their child is maybe taking benzos.
Well, I would say these are signs that apply not just to benzos, but really to any highly addictive drug. The first thing I would say is wide fluctuations in the child's behavior. Sometimes they're presenting, as the child we remember, with the sort of personality style that is familiar to us. And then other times they seem very altered in terms of either their alertness or their level of anger or their level of emotionality, or just even showing up. A very common sign and symptom of addiction is people just not being able to show up, or they're not being able to be where they're supposed to be when they're supposed to be there.
Yeah. So
those kinds of wide fluctuations in presentation, I think are really important. Looking for what we call sociopathic tendencies, which are sort of antisocial traits, lying, cheating, stealing, especially lying, I think can be a really early kind of sentinel event. So, when our child says, oh, I'm at Bob's house and they're really at Judy's house, and there's sort of no rhyme or reason that we can put together on why they might have lied about something seemingly innocuous as that. But this sort of lying habit is something that we should really watch for. Of course, impairments in function are a big one. And for kids, that usually manifests as lower grades, inability to get homework done, inability to attend in class or show up for class. Another important one is a decrement or a decrease in self-care, not sleeping enough, not bathing enough, not brushing their teeth, not exercising, not eating right, the kinds of, basic self-care that we all need to do to maintain good health.
So significant changes of behavior, for example. And any suggestion for that, Anna, if that's the case and parents are very concerned, who should they or could they talk to?
Well, I generally recommend if parents are concerned about addiction or substance use in their children, that they begin by trying to have a calm conversation with their child themselves, and not in a time when they're stressed and anxious, and hopefully when the child is not intoxicated, stressed, or anxious, and just reflect back to the child what they're seeing. We're seeing you, stay up all night. We're seeing you very groggy and late for school in the morning. We're seeing you unable to get your work done. We're seeing you lying to us about things that don't really make any sense for you to lie to us about. Reflecting that back to the child in a loving and concerned way would be the first step. And then, listening to what the child or the teen has to say about that. Denial is a part of addiction. So even in that loving, safe context, the child may not disclose. And then I would say the next step is really to get that child seen by a professional, somebody who has expertise in addiction medicine or addiction psychiatry. I'm really biased in this regard. I see a lot of families who take their child to see a counselor or a psychologist who has no training and expertise in addiction. And I think that is potentially problematic, because just as I received very little training in addiction in my medical school and psychiatry training, that's true for most mental health care providers. And the problem is that not only will they then not ask the young person about substance use or target it, they may even make it worse by doing something like prescribing Xanax, because they diagnose this person as having an anxiety disorder, insomnia, and they don't appreciate the risks of Xanax. So really important, I think, when you're looking for mental health care providers, find somebody who's addiction informed, someone who knows about how to ask those hard questions.
That's very important information. That was something I definitely wanted to get to. So it needs to be an addiction expert, no matter if it's a psychiatrist, possibly a psychologist, and do a good clinical evaluation, and then have a plan. Right. And hopefully, particularly when parents are mindful and informed, hopefully non-pharmacological, if at all possible.
Right. And also to think about, different levels of care, right? So outpatient care is okay for somebody who's struggling at the beginning of an addiction or with a minor addiction. But for people who are further down the road, they might need to go to residential as the first intervention, in order to get away from the drug, to get their frontal lobes back online and be able to see more clearly the impact of their drug use on their life. So think about this as a continuum of care. There's at the sort of least invasive part of the continuum is going to see an outpatient provider who's got some addiction expertise. Then there's the IOP, or intensive outpatient programs, where you sleep in your own bed at night, but you spend, a good part of every day in an intensive outpatient treatment program. And then the next level is a rehab or residential treatment program, where you go there and you sleep in their bed for, 30 to 90 days or longer.
And what are some alternatives to pharmacological, to using benzos? Just kind of list a few that you think would make sense for teens.
Well, there's individual psychotherapy, there's group psychotherapy, there's mutual help groups, which are not treatments per se because they're not professionally led, but that's like 12-step groups, Alcoholics, Narcotics Anonymous. There are lots of meetings for young people and for teens. the data show that people who actively engage in 12-step treatments get better, and probably even get better, maybe even have more significant improvements than people who get individual therapy from a professional treatment provider. There are, changing your day-to-day habits, doing things like engaging in more adaptive coping strategies like exercise, reaching out to friends, doing creative endeavors. So there are lots of healthier, more adaptive behaviors. We need to change our environment too, to decrease access. So this is things like just making it harder for our kids to get their drugs, which in some cases means cutting off their financial supply if we're giving them an allowance or a credit card. So, really, changing the external environment as well as thinking about changing what's going on in their heads.
And that may mean that parents have to look at themselves a little bit, excuse me, and their habits, such as popping a pill for every little ache or headache and drinking the casual alcohol at night.
Yeah. So family therapy is really important in many instances because sometimes parents themselves have, more minor functional forms of addiction, which can complicate things for the addicted child. So looking at the family systems, looking at addiction as an attachment disorder, and kind of reworking it as a family is really important.
And do you have any advice for drug education in school? Because as we're speaking, there has been change because of the fentanyl crisis. Do you have any thoughts what you definitely want to pack into drug education in schools?
Yeah, I think the neuroscience of addiction and what's happening in people's brains, it's what I emphasize in my book, Dopamine Nation. And I think when people understand the neuroscience, it can be an aha moment for them. And I found that even very young children understand this and that can be helpful. I think having things like, naloxone rescue kits on hand so that people know about that, even if just a way to signal how dangerous these drugs are, that people will need to be rescued or they may die, that can be very instructive. We learned from the DARE project that having something like police officers go into middle schools and talk about how dangerous drugs are doesn't help because, as I said before, sometimes that's appealing then to teens where they think to them, oh, that sounds cool, I want to try that. So we have to be very careful. What does help is interventions that improve social cognition and empathy and pro-social behaviors, even if they're not necessarily tied to talking about drugs per se.
And also including the students themselves.
Oh, absolutely.
Allowing them to add to the solutions and what is it they think they need in order to not be tempted and feel the peer pressure around them. Because it's out there.
Yes. And I think also even for, like middle school children, giving them an anonymous resource to call if they're already struggling with addiction and want help, someplace where they can go anonymously and get that help, really important.
Anna, can you briefly tell us what are the different forms? Are there only pills? For example, Xanax, do they only come in pill form?
I think there's like the pills or Z-bars, there are sort of different types of pills. It might come in powder form. I'm not sure.
And I think on the black market, it comes as those fake pills, but then they may crush the pills and snort it.
Oh, sure.
Smoke it with their joint, possibly too.
Yes. So that's always true that as people develop tolerance to a substance in pill form, they will often change the delivery mechanism in order to overcome the tolerance and make it more potent. One of the ways to do that is to crush the pill and snort it, because when we snort it, it goes much faster across the blood-brain barrier, and we get more of a high. So that's or crushing it and injecting it is another method.
Yeah, wow. So I know we come to the end. Anna, is there anything that you want to mention, considering that this is for parents, for teens, for schools, for all of us in the community? What else do we need to consider? What is the most important to solve the Xanax or benzo problem? The overuse, the popularity.
Yeah. Well, I guess in this moment, the one thing I really want to add is, express my condolences for your loss, and thank you for building this memorial to your son.
Of course. Thank you so much, Anna, and thank you for your time. I know there's so much more I would have asked, but I think we have a good solid core of information that hopefully will help others to stay away from benzos.
I hope so.
Thank you so much.
You're welcome. Take
Bye,
care.
Anna.
Bye-bye.